Good afternoon and welcome to Bridges at Lakeview Health, our educational series that connects addiction and recovery subjects for our communities across the nation. A little bit about Lakeview Health. Our mission: we are bigger than sobriety. We are a passionate team of difference makers who empower profound recovery through exceptional, dynamic, and evidence-based care for individuals and their families. We are Lakeview Health. Before we get started, I wanted to share a few housekeeping items. Throughout the presentation, participants will have the ability to submit questions by way of the Q&A box listed in the panel on the right-hand side of your screen. At the end of the presentation, the presenter will answer any questions you may have. Please note that all participants' microphones and video cameras are muted throughout the presentation. Within 24 hours following the event, we will email participants the post-test and course evaluation. As a reminder, to receive the certificate of completion for continuing education credits, you must be in attendance for the entirety of the presentation, complete the evaluation, and pass the post-test with at least a 70%. At this time, I would like to introduce Dr. Jarambi, our Chief Medical Officer at Lakeview Health.
Good morning, everyone, or good afternoon, actually. I'm so glad to see everybody here, and we have a lot of people online. As Donna said, I'm Dr. Lanty Jordanby. I am the Chief Medical Officer here at Lakeview Health. We are an adult disorder facility. We treat substance use and mental health. I'm also an addiction psychiatrist. I have the extreme pleasure of being able to introduce Dr. Jean-Luc Cadet. Dr. Cadet graduated from Columbia University College of Physicians and Surgeons in 1979. He did his residency training in psychiatry at the Department of Psychiatry at Columbia University and in neurology at the Department of Neurology at Mount Sinai Medical Center. He came to the National Institute of Drug Abuse Intramural Research Program in 1992, where he is presently an NIH tenured senior investigator and the chief of the Molecular Neuropsychiatry Research Branch at NIDA Intramural Research Program. Dr. Cadet has co-authored more than 300 papers and book chapters on the molecular neurobiology of substance use disorders, cognitive aspects of cocaine and marijuana use disorder. Presently, his laboratory studies the epigenetic mechanisms that mediate stimulant-induced changes in the expression of genes in specific neuronal cells within the brain reward pathways. Dr. Cadet has also shown that adverse consequences represented by contingent foot shocks can separate rats that have escalated their intake of methamphetamine into shock-resistant or addicted and shock-sensitive or non-addicted rats. His lab has shown that there are differences in DNA hydroxymethylation in the gene bodies of potassium channels located in the nucleus accumbens when addicted rats are compared to non-addicted rats. Moreover, Dr. Cadet's laboratory has shown that foot shocks can also dichotomize oxycodone self-administering rats into addicted and non-addicted rats. Dr. Cadet has served on the editorial board of Synapse. He is presently on the editorial boards of Neurotoxicity Research, Current Neuropharmacology, International Journal of Neuropsychopharmacology, Scientific Reports, and the Journal of Addictive Diseases. He is a reviewing editor for Scientific Reports, and he has reviewed scientific articles from many journals, including Journal of Neuroscience, Biological Psychiatry, Brain Molecular Psychiatry, JAMA Neurology, JAMA Psychiatry, Nature, Biotechnology, Proceedings of the National Academy of Sciences, among others. He has served on the program committee of the National Hispanic Science Network and has been a member of the program committee for the Society for Biological Psychiatry. He is, in one word or two words, a rock star. So without further ado.
Thank you. Good afternoon. Thank you for the presentation and the invitation. I've been enjoying my time here in Florida. So what I'm going to try to do this afternoon is review some of the work on the clinical and molecular neurobiology of substance use disorders that I've been conducting in my lab in Maryland. I'm also a member of the Society of Haitian Neuroscientists, which is a very important issue for me. But because most of you might be curious about where I come from, I decided before I started to do the talk to talk to you a little bit about my what I call tragicomic misadventures before I became a addiction physician. So a lot of people have heard about Haiti, but they don't know where Haiti is. I found out when I was talking to one of my classmates at Columbia that he thought Haiti was in Africa. But, but Haiti is not. Haiti is in the Caribbean, close to Cuba, and it's very easy to get from Haiti to Miami. That's why we have quite a lot of people trying to come over. I come from the northern side of Haiti, a city called Complicate. A lot of people know about Port-au-Prince, which is in the middle of the country. So when a lot of people have heard about Haiti because of the earthquake in 2010 at the time, I wrote a poem about what happened in Haiti. This is me as baby Jean in Haiti. And my mother liked to put things on her head. So, there were 3 boys, and all of us have picture with things on our head. This is a really bad picture. My older brother found it. I don't know where he found it, but he sent it to me, and so I like it. This is my grandfather, who was actually quite famous in Haiti. I was telling you guys that he died when he was 96, and he was still working the day before. And this is one of his paintings. And this is my class just before I left Haiti to come to Brooklyn. So I have that picture. And most of these, actually about 10 of them, the top 10 kids in my class became either physician or engineers. So this is the 3 of us with my father, but you can guess which one I am. So it's a test, it will appear on the test list. So I came to Brooklyn in October 1970, and this was myself in Brooklyn. And then, so that was the first time that I experienced winter, and I wrote a poem about winter blues, because it was really cold, right? You could say Haiti was in the Caribbean, hot all the time, nice weather. So I at the time, after doing my first winter, I said, it's time to go back to Haiti. But I didn't know about Florida at the time. I could have just said, time to come to Florida. And I went to medical school at Columbia, like said, and so and then in 92, while I was working in New York, I was attending assistant professor of neurology and psychiatry at Columbia. And most of the patients I was seeing had diseases that was really, I was interested in them, but they were not really impactful in terms of what was going on. So I thought it might be a good idea to come to the National Institute on Drug Abuse, and I've been there since 92. And so I'm going to tell you about some studies that I did with marijuana, cocaine, and then methamphetamine. So the first one, I'm going to present some data on the neuropsychiatry of marijuana addiction and notification for treatment. I think for anybody who's interested in doing treatment with marijuana users, I think this study is very important. We published this paper, and several other groups have now replicated what we found, and this paper has been published, cited more than 500 times. So it's a really important paper in the field. So marijuana, as you know, is the most commonly abused drug in the world. In the United States, there are 2 to 3 million users per year. The majority of users are between ages 12 to 17, and 1 of 12 new users will become addicted to the drug. Okay? In terms of this, when I was in college, I played soccer in college, and half of the team was smoking marijuana at the time. And so I would tell them, they'd offer me marijuana, and I said, no, I really want to be able to play tomorrow because marijuana is going to affect your performance. And I didn't know whether that was true or not at the time because I was in a physician, but I was just making it up just to say no to using marijuana because I was really scared. And so then we would keep on losing these matches because half of the team actually couldn't perform. There's subsequent many studies afterwards that have actually shown that smoking marijuana does impact your physical motor performance. Now, so in this study, what we wanted to know is to determine if there were any neurocognitive deficits in patients who use marijuana, and we also wanted to know whether these deficits would last after 28 days of abstinence. So we admitted the young people, mostly, we'll show you the ages later on, we admitted them on an inpatient unit where they had complete restriction. Nobody could come out to give them marijuana, so they had no access. And we also measured urine on a regular basis. And so we also wanted to know if the deficits, whatever deficits we identified, were related to the amount of drugs that they were taking. So this is the patient who they had to use marijuana as a drug of choice. You've been using marijuana for at least 2 years, at least using the drug 3 times per week. And you'll notice when I show the data that this was really important because as you will see, people who use marijuana not too often don't have the same type of deficits. And importantly, they have to be HIV negative because HIV disease is associated with cognitive dysfunction. So, can you still hear me in the back? Okay. So, so when we admitted the people, we, as I mentioned before, they came in, we monitored them, we made sure they had no access to marijuana for that month that they were there. And when they came in, we also measured the quantitatively, not just like a unit test that showed presence of, we actually measured the amount of drugs that they were taking. And we give them a complete neuropsychological battery. I don't know how familiar with the batteries you are. So we measure language, performance, verbal memory, visual memory, attention, and concentration. We measured executive function of frontal lobe using the Wisconsin CADSO, visual construction and perception, psychomotor speed, and many of the study with finger tapping, right? So a lot of this you learn when you're a medical student, but this was done by a neuropsychologist. So those are the patients. As you can see here, the age, they're young, okay? Most of them have gone through close to finishing high school. They have average IQ, and mostly male in the studies. What I found when we're trying to do inpatient unit studies, it's very difficult to recruit women for inpatient unit. And then they're giving a lot of different explanation for that. But in studies like this, we can find mostly male. And then in this study, most of the people in Baltimore who were using heavy quantity of marijuana were African American males. and most of the patients were right-handed. So I mentioned that we know how much marijuana they were using, and we were able to break the patient into 3 different groups. People were using not a lot of marijuana, others were using medium range, and there were some people who were heavy users of marijuana. So when you talk to those individuals, I don't know whether you've seen them here, there are people, young people who are sitting in their parents' basement, or whether it's a grandparent or mother or father, where they spend all of their time smoking marijuana. And a lot of times I would say, where do you have time, money to buy all this marijuana? They never give me an answer to that. But that's all they did all day long, right? Sat down and used marijuana in the basement, didn't have a job, didn't have anything else. So for them coming into an inpatient unit to participate in a study where they were going to get paid because the treatment wasn't really a big issue. So on the Wisconsin card sort, this is what we found. As you can see here, the heavy use group had more deficits than the other group. Okay, and if right in terms of perseveration, like you know what perseveration is. So again, the heavy group was the group that was showing most of the deficit. There were no real significant differences between these two, but both of these groups were significant different from the light users. So, and I can tell you that now. So the light users, when you compare them to controls, there were no difference. Right? They would just look like normal. And finger tapping, right? Again, people who were sitting at home in the basement of their parents or grandparents also were the ones who had abnormalities. The medium and light group looked just like control. So what we then were able to conclude was that marijuana users have persistent decrements in performance even after 28 days. So we measured the performance at 3 days after they were in the hospital, and then we measured it again at 20 days later. There were no differences between early testing when they still had marijuana on board and 28 days testing where they didn't have any marijuana on board. So the deficit in visual memory, executive functioning, visual perception, psychomotor speed, manual dexterity, they all lasted for at least 1 month in that study. There are other groups that have done studies where they look at 6 months, and some of the changes, there's some improvement in verbal memory, but the psychomotor speed problems seem to persist for really a long period of time in the heavy marijuana use, not like marijuana. So now, so this was marijuana, right? So now I think everybody knows, based on the literature, that heavy marijuana use is not without some consequences. And some of these consequences are quite negative because that can impact work, right? So, and the other people who have reported that now. So now let's talk about cocaine. So while we were doing this study, we're also recruiting for, at the time, crack cocaine was a very popular in Baltimore. So we were able to recruit people for who were using cocaine. So one of the things that we should be aware of is the psychiatric complications associated with cocaine use, right? So you're all aware of them. Patients can suffer from strokes. They can have problems with aneurysm, right? Vascular malformation, hemorrhagic stroke, ischemic stroke. A lot of this occur because of cocaine blocks the reuptake of dopamine, norepinephrine, And when the level of these neurotransmitters are increased in the brain or in the periphery, in the vasculature, you can end up with strokes and hypertensive crisis. So we wanted the same thing that we were doing with marijuana. We wanted to know the same thing about cocaine users. And the study was very similar. These are the inclusion criteria. They have to have been using cocaine by any route. They had to use cocaine for at least a year. In this case, they had to use cocaine at least 4 times per month. So we thought that we didn't really need them to be using cocaine a lot because cocaine has all these vascular issues that it's caused while marijuana doesn't. So we wanted people using more marijuana. But in this case, we went with 4 times per month for cocaine use. And then again, always we do quantitative tests of cocaine metabolites. And then, so we also had some exclusion criteria, and they couldn't have used any other drug except nicotine. In which respect, we probably should have excluded nicotine use also, because nicotine use is also associated with cognitive deficit and some other issues. Those are the patients. You have the control group, and we have the cocaine group. So we had more cocaine users because they were willing to come and stay on the ward than the marijuana users. And they all had average IQ, just like the cocaine users. And again, in this case, most of the subjects, participants, were African Americans. Crack cocaine in Baltimore in the 90s was a major problem. So we were able to quantify how much cocaine they were using in terms of grams per week. And we also had the length of time that people have been using cocaine. So it varied from 1 to 25 years. So some people were using cocaine for a long period of time. And then the one thing that wasn't part of the study is that we noticed is that the longer people were using cocaine, the more aged they looked. It was really sad to see that. So those are the results. So cocaine abuse is associated with significant dose-dependent effects. Just like with marijuana, cocaine use is associated with greater number of deficits, the more drug, the more cocaine somebody used. So, and then these changes were, you see here, right? Crosby, Wisconsin Carson, they all have abnormalities. Line orientation, they couldn't really draw a line properly. They had abnormal reaction times. They also had a lot of repetition errors. And the one thing that I wasn't expecting is that the reaction time. I was actually expecting people to have better reaction time when they were in cocaine, but that wasn't actually the case. They really, based on whether they were using a high quantity of cocaine, they had a lot of deficits, and they had some difficulty putting a small item into group tech. So this one is the one that I really wanted to show you because it really shows some of the neurological abnormalities that people have. They couldn't track, right? The high cocaine users couldn't track properly. So cocaine is not with that major neurological deficit. So in conclusion then, what we decided was that chronic heavy users of cocaine have persistent neurocognitive deficit. So we did the same thing that we did with marijuana. We tested them early, at 3 days after they were in the hospital, and about a month after they were in the hospital. Then doesn't really matter. You test people early when they still might have some cocaine on board, and test them later when they don't have any cocaine on board, they still have deficits. So that's something for you to keep in mind. And I'll talk a little bit in the next slide. So they have more behavioral impairment, the higher the dose, and there might be, we believe that those are direct effect of cocaine because there's a dose-dependent effect of the drug. So one of the things that in papers, that whenever we write papers, we touch on treatment, right? So if you have somebody come in and they're heavy using of marijuana, heavy user of cocaine, and you try to push the treatment of everybody in the same way. What ends up happening, and this has been shown in the literature now, is that some people will do well, others won't do well. But what I think we should do is to put people through neuropsychological testing in order to identify patients who might have cognitive deficits. Okay, so when you're seeing that a patient might not be following your treatment program, it might not because they're a bad person. It could be that they're not capable of following the instruction because sometimes, as you saw, they have memory deficits. They might not remember what the program is. Okay? So if you do the neuropsychological testing, you'll identify the patients, so then you'll say, okay, this person is going to need cognitive rehabilitation, huh? While the other person might not be. They might just need to be treated with that cognitive rehabilitation. But I think it's really important that patients who come in for treatment be really evaluated at the neuropsychological level. So now let me talk to you a little bit about the basic science stuff. This is going to be a little longer because it's going to involve a lot of basic science issues. So while we're doing this, we wanted to develop models of methamphetamine use disorder in rodents. It's very difficult to study some of the issues that we wanted to study in humans. We wanted to develop pharmacological treatment or cognitive treatment based on the basic effects of what drugs do to the brain. Okay? And a lot of the consequences, basic neurobiological consequences of methamphetamine are at the epigenetic level. So we cannot use we cannot do biopsies of the brain of humans in order to test hypothesis that we might have. So what I'm going to show you here, I'm going to show you evidence that methamphetamine does cause epigenetic and transcriptional, that means changes in gene expression in various brain regions. Okay? So in terms of methamphetamine, 27 million individuals use amphetamine type stimulants in the world. 27 million. Okay? So I go give talks around the world, right? So when I go to Korea, all they want to talk about is about my work on methamphetamine. If I go to Japan or Hong Kong, it's the same thing. So I say, well, what about cocaine? He said, well, we don't see cocaine much. It's all about methamphetamine and opiates. Heroin is a big issue. In North America, mostly the United States, there's a high prevalence of methamphetamine use between ages 15 and a really wide range of people who abuse the drug. 375,000 Americans aged 18 and 25, and 1.2 million aged 26 or older are active meth users. It's a lot of people. In 2017, meth-related overdose death in the United States increased 7.5 times compared with what was going on in 2007. Okay, and obviously you know that there is no FDA-approved medication for meth use disorder. So during the time when we were reading or hearing on the news about opiate overdosages, the methamphetamine overdosages got completely ignored. I do not understand why that is, because when I would give talk locally or I give a talk at the DA, and I was talking to some people in the CDC, I said, why did guys not paying attention to methamphetamine over? Okay, so but the data was right there. People who were seeing meth users were complaining about the fact that the overdosages were going on, but the news totally ignored. So it's really important for us to keep those overdosages of meth users. Some people say it's probably because the opiate overdosage were from middle class, upper middle class Americans, while the methamphetamine overdosages were from middle class or lower middle class Americans. I'm not sure why that is, but I think a lot of people are starting to talk again about meth overdosing. So, as in all of the different drug substance use disorders, meth use disorder is characterized by 4 C's: loss of control of a drug use, right? You could replace this with marijuana or cocaine, craving of the drug, okay? Continued use despite adverse consequence, right? And the compulsive use of drugs. So those are part of the DSM criteria for substance use disorder. Now, I like to show this slide because in terms of the cycles of meth use disorder, right? So the initial intake of methamphetamine, it's usually by pill form, right? Somebody might have stolen the methamphetamine that might have been prescribed for their sibling that has ADHD because they were not responding well to Ritalin. After they increase the oral intake, then they start finding ways to have more methamphetamine, and then you get to a point where they escalate their use to using IV, smoking other woods instead of just the oral wood because they become tolerant, their brains become tolerant to the effects of methamphetamine, and they maintain this use, and then they get to a point where they get into this meth binges on weekends and don't start taking the drug until they run out of drugs. And they usually do that together with other people who bring their own methamphetamine in. So they share the methamphetamine. And when they run out of methamphetamine, then they go into abstinence or they withdraw, right? And I'll show you a slide of the consequences of not having drug on board and how that drives multiple relapses of those patients. So this is a nice slide to remember in terms of the clinical presentations of patients with methamphetamine use disorder. So immediately after they take the drug, within the first 5 to 30 minutes of taking the drug, they're euphoric. That's why people take most drugs, right? The euphoria associated with the drug. They're more aroused, okay? But they've also developed hypercardia, right? Tachycardia, the hypertension, okay? everybody who takes this drug will have increased blood pressure. And those are due to release of epinephrine in the periphery, okay? And the rapid release of dopamine in the brain. So the euphoria, all the stuff associated with the brain related to dopamine, and most of the symptoms in the periphery, like hypertension or fast heart rate, is related to epinephrine and norepinephrine. Okay, so that's within the first 5 to 30 minutes, and then I should say to you that methamphetamine, in comparison to cocaine, the effects last much longer for methamphetamine than cocaine. Some people have switched from cocaine to methamphetamine because of that. Right? So around 4 to 16 hours, they have the activity that you saw initially is still there, right? They're still hyperactive. They're still, they have some short-term improvement in cognitive domains. And later on, I'll talk to you about medical students, physicians, nurses, truck drivers who take this methamphetamine because of this, right? They have pupillary dilation and hyperthermia, right? So everybody who's, whether they're addicted or not, who takes methamphetamine will develop increase in body temperature. It's one of the side effects. And depending on the dose of methamphetamine that they're taking, this is actually like kills people. The increase in body temperature kills people. And the other thing that you should keep in mind is that if you are treating somebody who works in emergency room or have a physician who works in emergency room, don't try to give these people a lot of fluid. The best thing you can do for a patient with methamphetamine who present without hypothermia is put them in an ice bath. You want to decrease that body temperature down fast. Because why? The high temperature also is reflecting high temperature in the brain, right? You know that high fever can cause damage to the brain. So get rid of that high temperature as fast as you can. Then they go through these benches where they can vary from 10, mostly on weekends, 3 to 15 days, depending on how much methamphetamine is available. The larger doses required to achieve the same intensity. You remember the slide I showed you at the beginning when they take the oil, they're feeling great. But over time, they really do become intolerant to the drug. They need to take larger doses. They need to smoke it. They need to inject and to get the same intensity. And they don't feel the initial rush that they felt at the beginning. And and then when they withdraw from the drug, they run out of drugs, they can suffer from depression, right? Hypersomnia, irritability. And some people have actually committed suicide after withdrawing from a high level of methamphetamine. So this is important to keep in mind in terms of suicide prevention. And why did they go back? They hence craving for the drug. They go back. And one of the problems clinically is that some of users who have used for a while go back to using, forgetting that now their system is readjusted to not completely normal. And they go back and use the same amount of drug that they were taking before stopping. That's where the overdosages come in, right? So they're not willing to, they're not planning to commit suicide in that time. They commit overdose and might die. And if during the overdose, the hypothermia, they ended up in the intensive care unit, and sometimes they cannot be saved. So this is the basic science I was talking to you about. I wanted to show you how methamphetamine works. Methamphetamine can get through our brain blood barrier very easily. It's very lipophilic. But then it goes to those catecholaminergic neuron. In this case, I'm showing you dopamine neuron, but it does the same thing in norepinephrine and epinephrine. Okay, so and it gets into the vesicles where dopamine usually is located, and then it causes a release of dopamine. And then when dopamine gets released in the neuron, also gets released in the synaptic cleft, the space between the presynaptic neuron and the postsynaptic neuron. And we have all these receptors, dopamine receptors, which there are 5 of them. The dopamine interacts with the receptors and cause all of the side effects that we see with methamphetamine. Okay? And, so even though we know this, we don't have a good way of developing pharmacological treatment for meth use disorder, right? That is because it's not the acute effect of the drug are not the reasons why people stay addicted to the drug. They have these epigenetic changes that I mentioned to you in the top of my title. So the other thing I should tell you about this is that when methamphetamine does this, it causes toxicity. So we publish a lot of papers showing that methamphetamine use is associated with toxicity in the brain, so that it causes this depletion of dopamine. And then if you remember, Parkinson's disease is associated with depletion of dopamine. So methamphetamine is toxic to those neurons that are impacted in Parkinson's disease. So you can see how people who use methamphetamine over a long period of time, and there are at least 3 papers in the literature supporting this now, they can develop Parkinsonian symptomatology later on. And then I wanted to show you how, if you give methamphetamine, just based on the slide I was showing you before, that you can have a large increase of dopamine that lasts for a long period of time, right? 300 minutes. Now, if you were to do the same experiment, and people have done this with cocaine, cocaine never caused this kind of release of dopamine in the brain. So the level of cocaine, if you were to do this, comes up on here, and it goes down very quickly, right? So you can see now, if you compare this slide to the slide that you can visualize for cocaine. That's why people switch over from cocaine to methamphetamine, right? But what they are not thinking of is that much dopamine is toxic to your brain. Now, we're talking about this, I'm talking about this, as if everybody who's exposed to a drug becomes addicted. That's not true, like Nancy Reagan, when she was saying this is the saying that, wow, this is a drug. Some of you might be too young to remember this, but whenever you take a drug, your brain is like fried eggs, right? Which was kind of really ignored. But be that as it may, but the reality is, and Jim Anthony published a paper in '94 quoting the percentages for all of the different drugs. He didn't have methamphetamine in his study at the time, but heroin, you can see 20 to 30% of the people become dependent on the drug. Marijuana, about 9% become dependent. But nicotine, there's a really significantly high number of people become dependent on nicotine here, right? So the percentage is really very cocaine, 17%. When I read that paper back then, I was very surprised that only 9% of marijuana users actually become dependent on the drug. But most of these are people who are sitting in their basement, parents' basement, smoking marijuana. The slide doesn't have methamphetamine because I wanted to just show Jim Anthony's work. But there's a recent paper published last year looking at meth users, 50%, right? So you have heroin about 38%, 50% of meth users develop meth use disorder. It's a much more potent drug, higher than the OPA, even though all we're talking about are the OPA. But 50%, keep that number in mind, that's a lot of people who meet criteria, DSM criteria for meth use disorder. So I wanted to know if it were possible to develop a model, right, as the data showed, not everybody who takes the drug develop a DSM type disorder, right? Can I use, and then one of the criteria, you remember, in the DSM is this continued use despite adverse consequences. So we wanted to know if we could do that with methamphetamine. While we were thinking about that, we became aware that others had done studies like that with alcohol and cocaine. So instead of reinventing the wheel, we say, oh, we'll use the same type of experimental approaches that they use in their studies, right? So we use food shot, okay? And so you can have a rat, okay, that already likes to take cocaine or likes to drink alcohol, and if you give them food shot, you can separate the group. There would be rats that no matter what you do to them, they'll still keep on drinking alcohol. And there are also rats, no matter what you do to them with the food shot, they still keep on taking cocaine, right? So those are the ones who are addicted. So when I was reading these papers, I was thinking, okay, it's just like the people when they go to prison, right? They go to prison and they find a way to get whatever the drug of choice into the prison, and then obviously the people who are guarding them, quote unquote, are involved. Otherwise, they wouldn't get the drug into the prison. But they still are taking the drug in prison. Now, we think in prison we want to be on the best behavior. They're still taking the drug. So we did the same thing with methamphetamine. You might have seen this before or not, but this is what you can train a rat to do. So you can put a rat in a box, Skinner box, where they have access to 2 levers, right? So one of the lever, when they press one of the lever, they get saline solution, no drugs in it. And the other lever, when they press it, they can get cocaine, oxycodone, methamphetamine. In this case, it was just methamphetamine, right? People have done experiment where you have access to 2 levers, you get opioid in one and methamphetamine in one. But guess what? The rats like methamphetamine there. So in this case, the rats quickly discovered which lever was giving them methamphetamine. Rats really like methamphetamine. So, and then their brain system, like ours, the same central tegment, they have dopamine like we do. So they like it the same way humans also like methamphetamine, and for the same reason. They're feeling euphoric. I mean, it's too bad that I cannot talk to the rats after. And then but when we punish them with the food shot for 13 days, right? So 50% of the time, when they press the lever to get methamphetamine, they get a food shot, right? But it's not predictive. It's not like you press this time, you get methamphetamine with that shot. You press next time, and every other one. It's not predictable when they're going to get the shot, right? So if they go to the thing, they don't know whether they're going to get shot plus methamphetamine or methamphetamine plus shot. So they don't know. They cannot predict it. And then after we do that, we can do a drug test. So we take them, we would no longer give them drug, and then we see how much they're craving the drug. And then they crave the drug. They'll still go to the level where they will get the drug, trying to say, oh, where's the methamphetamine? Where's the methamphetamine? So this is like the first study with this. And then you can see how the animals they are pressed the lever. They quickly learn which one would give them the methamphetamine. Huh? So, and then after they escalate their use, right, escalation, they'll maintain. They tend not to go beyond a certain, because if they go beyond a certain amount of methamphetamine, they're going to die because it's too much, right? They develop brain problems and hemorrhages, and they lose a lot of weight. We did an experiment where the rats were taking a lot of methamphetamine. We had given, in this case, we give them 9-hour access, but if you give them 14-hour access to methamphetamine, they'll kill themselves because they lack methamphetamine. So, but if they have only 9 hours, they don't do that. And then, but when we give the shot, the one in blue, you can see some rats will basically stop taking the drug as we go higher in terms of the intensity of the shot, right? While others will continue to take. Okay. When we go to the high level, these animals will decrease also. But there's there's a group in France that has done this with cocaine. If you go to high enough shot punishment, all the animals will stop. We never really did that. So this is showing you shock sensitive, the non-addicted rats, and shock resistant, the addicted rats. In this experiment, these animals, they decrease or stop their intake of methamphetamine. And the shock resistant decrease, but not to the same level. And then if you look at which craving of the drug, the shock sensitive crave the drug much less than the addicted. Right. So then you have to go fast. I'm going to show you some of the epigenetic effects of the drug. So in the same experiment, what we did was we did the experiment and we sacrificed the animals and we take their brain and measure epigenetic. And then what we found was that there were a lot of potassium channels. I don't know if you remember the potassium channel that were impacted in the nucleus accumbens of these animals. And then what we found was that in the brain of the non-addicted rats, there were increases in potassium channel expression. So potassium channel usually suppress neuronal activity. So we think that in the animals that are not addicted, the increased expression of the potassium channel is suppressing the activity that's causing them to take the drug. So what we showed in that study was there was increased DNA hydroxymethylation in the non-addicted rats, and there were a lot of potassium channels that showed the increased mRNA expression in the nucleus accumbens on the non-addicted rats. And our experiment that was published in Molecular Psychiatry in 2017 identified for the first time a potential role for different classes of potassium channels in promoting abstinence. So as you know, there are some potassium channel activators that are available clinically. So the plan is to try to use some of those to see if we can suppress meth-taking behavior in animals and then in humans. So what I've shown you with the methamphetamine is that methamphetamine exposure, depending on individual factors, can cause changes in the transcription of genes. Some of the genes that we have identified, and I haven't shown you that data, as related to stress, and some of them are in the mitochondria. And then if you give shot that represent adverse consequences, that can impact what you also find. But in terms of the meth exposure, what you can have in the brain are physiological changes, and then that express themselves as behavioral changes. And so we have this memory deficit. All of these are secondary to epigenetic and transcriptional changes, and then that's how you end up with meth use disorder. So if you have a meth use disorder that has all these abnormalities, we need to know what they are so that we can try to treat patients. Anyway, I'll finish by showing you the lab, the people in the lab, and I'll take questions. If there are questions, go ahead. Go ahead.
In your studies, we know that methamphetamine can be to affect sleep.
Mhm.
How is that a variable? Because some of the same neural functions happen because of lack of sleep, not being able to get the deep sleep to carry functions to your hormones and all that. So that a big variable too. But a lot of times they say after 11 days, they found, like, I think one research paper I read said after like 22 days, all the rest of the day was like sleep when they get stimulated. I was just wondering, that's bad, but do you think sleep
So
is
in this,
variable? You have to
that's a very good question. In this, so the question was whether sleep might influence what we're seeing, right? So we didn't study sleep in this study, but it is well known that methamphetamine is associated with use disorder, is associated with sleep disorder, right? So actually, one of the basic scientists interested in sleep, what it does to put the electrode and actually measure sleep in the rats. But it gets really complicated if you want to do studies like this. So what we wanted to know is, okay, are the epigenetic changes that we see, whether they're related to sleep or other things? Well, one thing that we found was that there were differences between the addicted and the non-addicted rats. So we could develop treatment, whether it's sleep-related or not, that would impact both sleep and also the self-administration of methamphetamine. So that's a good question. That's important. In the case of marijuana also, we've noticed that people who do poorly also seem to have more sleep disorders. So sleep is very, very, very. Anything else?
Donna has two questions.
Yeah, we do have two questions. The first one is, has the percent changed of those becoming addicted to marijuana changed significantly since the study on the slide due to increased THC levels?
So in the study that I did with marijuana, so the people have higher level of THC and they also took more drug. They have more cognitive abnormalities, definitely related to that. We haven't done any studies looking at marijuana, self-administration, and epigenetic changes. Those are actually very difficult to do because rats don't like to give themselves marijuana. People have tried all kinds of different ways to get the rats to take active ingredient agonists at the cannabinoid receptors. They don't like it. And I think that's probably why we only have 9% of people actually developing marijuana use disorders.
Okay, the next question. What about the new THC versions, Delta 6 and 9? Does it make a difference?
I don't know. We haven't studied those, and there haven't been too many basic science studies of those either. So I don't know.
We got one more now. Are the genetic changes in result to someone who is actively using use prior to having children directed towards maternal or paternal?
Okay, so those are tough questions. Nobody's done any studies with methamphetamine yet, but people have done studies with opiate in animals, not in humans, but in animals, showing that you can get transgenerational effects of the drugs. And in those cases, they use either mother or the father, and it seems that the the problems were more paternal. A lot of the problems were more paternal than maternal. So, but in both cases, you can end up with complications that are transgenerational. So right now, the Institute is supporting some of the studies in rats, but we don't know in humans yet. So one of my postdocs is very interested in this issue, and I think if it can happen in rats that have very similar system that we do, I think it's very, very important that people stop using drugs. If you can get people to treatment, to stop using drugs as early as possible. And definitely don't use drugs during pregnancy because placental exposure is a major problem. Yes.
So is there any indication or impression that for heavy users, we should delay their treatment for some time so that they have time to be non-users before trying to educate them? Would that be useful or helpful?
So I think that's a really, 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 really important question. So in our papers, when we talk about treatment, we'll try to skirt that issue. But if you remember the studies, the cognitive studies that we did, the same cognitive deficits that you see early on are the same ones that you see later on, right? So from my perspective, if you admit a patient, you do the cognitive studies early on, you're going to identify the ones that you can impact almost immediately through psychotherapy or whatever it is that you're doing in your treatment program. And then you'll identify the ones where you're going to have to supplement whatever else you're doing. So delaying treatment doesn't really make a difference, right? Because you know, right? The same deficits are there at 3 days, they're also there at 1 month. So I think the earlier you get people into treatment, you know how to supplement their treatment, the better you are. But one thing everybody should be doing now, and I've been trying to, in my papers I had about that, everybody should get like a full battery of neuropsychological testing. And instead of just plugging everybody in the same treatment program, should differentiate what people are, right? So, and in order to, and people are talking the same way about schizophrenic patients, right? There's some of them that have cognitive problems, and others don't. And, people are trying to develop better treatment, different treatment for different groups of patients. Anybody else?
We do have a few more. Any studies with increase in psychosis, specifically schizophrenia, with increase of THC levels?
No, the studies, I did a presentation about THC and schizophrenia. I know a lot of people like to talk about this. The evidence is really not very, very, very strong. It is true that the patients would smoke more nicotine mostly, but they also smoke marijuana. I think the pathological mechanisms involved in schizophrenic type diseases are probably similar to why people use THC. So that if you use THC and then you have a proclivity to develop schizophrenia, it might induce you developing it early. But it's not the marijuana that's causing the psychosis. It's the pathology, the brain pathology that already existed. Then you do that. Otherwise, there'll be many more people. I mean, the numbers of people using marijuana is vast. Okay, so if there was a one-to-one correspondence between marijuana and psychosis, there'd be most people with psychosis walking around. It is just not the case.
Okay, next question. Are treatment programs utilizing your findings in planning treatment?
In terms of the cocaine and marijuana, the treatment program we are doing complete evaluation. I mean, that's been around for a longer period of time. So people are doing that. In terms of the methamphetamine studies, they're recent. So there isn't any group really, even ourselves, we haven't really used the potassium channel findings to use in animal models, right? So, but the cognition, people are doing that. Several groups are evaluating their patients. They're trying to plan programs that are based on neurocognitive deficits. So that's been around for a while now that people are doing it. But and then it's not just our papers. A lot of different groups have looked at their patients and have found the same thing. And so it's definitely a way that we should do in treatment program.
Yeah, I see one more here. It says, do these studies complicate the diagnosis of physical mental illness versus drug-induced mental illness symptoms?
It doesn't really. But I've always done this even when I was doing my psychiatry residency, even before it became popular to do. Whenever I would have a patient to come to the inpatient unit with acute psychosis, I would almost always measure drug intake, right, in a urine. But back in the days, we just have a strip. You say, yes, there's a drug on board. No, there isn't. But now you can get quantitative assessment of what drug people were on, right? So I think we all should do that when people come in emergency room. If we are working in an acute hospital or a treatment program and people who present with symptoms, we should measure quantitatively what drugs there were taken, okay? So when I was a medical student at Columbia, there were people coming in with depression or psychosis from upper middle class backgrounds. And, I remember this one woman during my medical school interview, I said, have you ever taken a drug? No. Not for diet? No. And then, but we sent a urine anyway, and the people attending didn't want that. And then, so he came back, amphetamine, right? So I went back, I said, wow, it says amphetamine. That's a drug. He said, oh, yes, my doctor was giving me amphetamine for weight reduction. So basically, what ended up happening is that when the doc decided he wasn't going to write the prescription anymore, he went into withdrawal and developed depression, right? So a lot of our patients might be taking drugs. So it's really, really important that we know what drug they're taking, because that might impact the way we treat their depression, their psychosis. And in the case of drug-induced psychosis, you could just have to wait for the drug to clear, and then that person is no longer psychotic. So it's very, very important to do. It doesn't complicate it. It's just you have to be aware that those are possibilities.
A lot of time bipolar.
Okay, we have a part 2 to that question that says, what about the lingering damage of the drug abuse?
So that again?
Lingering damage of drug use.
Oh, okay. So in the case of marijuana, so in our study with marijuana, so I'm going to talk about different drugs. Marijuana, what we found was that the heavy users have structural brain abnormalities that we documented with imaging studies. Other people have done functional imaging studies, have also documented changes in heavy users of marijuana, right? So there's this. But those studies are usually done after a month or 6 months. Studies, I think I know of only one study where they look at 1 year, but there seems to be improvement by 1 year. Okay? For cocaine, we've also published papers looking at structural MRI Then we also have documented abnormalities in the frontal lobe, right? And then we think that some of the cognitive deficits that we see with patients are related, in terms of decision making, are related to the changes, the structural changes in the frontal cortical areas. Now, in terms of methamphetamine, that drug is really tough. We've published papers in animals. Other groups have published papers in humans showing, as I mentioned a little bit earlier, that there are long-term deficits in the dopamine system. The level of dopamine is really much lower than normal. If you look at the transporter, the dopamine transporter, which is really an important protein that really helps with dopamine metabolism, that's also very decreased. There's another protein that's in a vesicle inside the dopamine terminals that really sequesters dopamine. Methamphetamine also damages these transporters. So there are three important proteins in our brains that are impacted in Parkinson's disease, and those are also impacted by methamphetamine. Now, my lab, quite a few years ago, maybe 10 years ago, we were the first lab to show this, and other people have actually now replicated these studies. Methamphetamine can also kill non-dopaminergic cells. So when we first saw that, we said, why? We had to repeat the study multiple times. And sure enough, it does it. Now, so you have cells, dopamine cells, that are involved in Parkinson's disease. And then we have cells that are involved in Huntington's disease. All of these are impacted after methamphetamine. So methamphetamine is really a bad drug. I mean, no matter how crazy I became, I would never take methamphetamine. So you should try to get your patients to stay away from methamphetamine.
So in the same idea, doctor, with many states legalizing marijuana and THC levels being higher, more concentrated, is there permanent structural damage for those who are still in the stages of brain development, 12 years old to 20 years old?
Mm-hmm. So there are 9 guys supporting studies to look at developmental impact of marijuana. And people are talking about this. I think it's going to be an issue. But those studies, they're still in process. And the studies that we've done, and if you remember, it's really the heavy users of marijuana who are going to develop the abnormalities, the cognitive abnormalities, structural abnormalities. So those people are addicted anyway. And then so they're part of that 9%. So the decision to legalize marijuana are going to be separate from the medical impact of the drug. Because there are other drugs that are really legal. Alcohol is one, right? And I can tell you, when I was writing a paper that I published in, I guess, 2004, reviewing the impact of marijuana, heroin, cocaine, methamphetamine. Okay? And then there was another group that was writing on alcohol at the same time. But since I was doing this, I decided to look at the alcohol literature just for comparison. Alcohol has caused more, has been shown to cause more damage to the brain than marijuana. Okay? So if nobody's talking about let's do prohibition, right? So whenever somebody start talking to me about not legalize marijuana, I say, okay, let's do prohibition for alcohol also. Because alcohol is definitely more damaging to the brain than my. Yes.
Is Adderall is a methamphetamine, or it's an amphetamine.
It's a combination.
Is there another drug that one can take, Adderall for ADD?
So usually people start with Ritalin, right? And then so when Ritalin they don't respond well to Ritalin, then doctors might say, okay, try this. Adderall is a good drug, right? And it works. Now the dose that the doctors, physicians are using and giving to children, they're not toxic dosage, right? They're not doing the same thing that I'm describing about methamphetamine, right? The other thing, even with methamphetamine, if you take animals that are really young, and then you compare them to adult animals, and you give the same dosages, there's no toxicity in the young animals. All of the toxicity in animals that are older. Right? So it's very important that people keep that in mind. The doses, using the Adderall for ADHD, the dosages work, and people do well on them. The kids do well on them. Don't take your kids off Adderall.
If it's, just follow-up question, if it's someone who's in recovery, Adderall is not recommended, correct?
I don't see if so, there are people who grew up with attention deficit disorder who became adults with attention deficit disorder. I think they should be treated well. Okay, and then because they're not functioning otherwise, right? And I think it's an important thing. The dosages are not the same dosages that people are taking IV that's causing the toxicity. If you have somebody that needs Adderall, use it. Okay?
Donna?
I think Evan mentioned about the CME evaluation. If you just turn this in and we're giving the
Right. Right, so whenever you're finishes there, gives it to me.
and those online will have this too.
Great. Thank you so much.
Thank you for inviting me.